So I think we'll go ahead and get started. It's 5 after. We have a very special guest here today. Patty Robinson is going to be presenting on fact and pediatric patients, populations. We're going to start out with some announcements we have to share. I guess the first announcement would be our next meeting is going to be held in October. So we will not have a meeting for September because of the holiday, Labor Day holiday. And our October meeting will actually be during the conference. So you can join us in person if you are attending. It's going to be, I believe, the Saturday, which is the 26th, very early at 7 a.m. So bring your coffee, bring your breakfast, and it'll just be nice to meet everyone. I'll have kind of a recap of the year, talk a little bit about planning for the next year, and believe it or not, start talking about our kind of ballot and people who want to be a part of leadership, and there'll be kind of a voting and nomination process. So we'll talk about that then. So we'll see you in October. And in terms of kind of the conference, I think you can start registering. Obviously, there's a lot of Peds focused content we really encourage you to check out. There's actually 2 pediatric focused ELOs. So we have our SIG ELO that's sponsored by us. Pediatric focus on digital technology, social media, and device use throughout development, understanding the pros, cons, and practical applications. So we're going to talk about all things digital. We're going to talk about social media. We're going to talk about phone use, things like that, and all across the age ranges. So we hope that you can join us for that ELO. Actually, Amelia and Allison also have an ELO, correct?
We do, yes. We're doing one on gender care is primary care. So and it's gonna be great.
Awesome. So you got 2 to choose from, which is nice. And then I'm gonna let Jonathan talk a little bit about the certificate.
Yep. Hi, everyone. So here we're really excited to announce that we'll be offering the pediatric certificate for the CFHA in-person annual conference. And so you'll have an opportunity to receive a certificate by attending over the course of the conference, either 3 concurrent pediatric sessions, 30 to 60 minutes, or attending the ELO and at least 1 concurrent pediatric session. And so really look forward to seeing you guys there. And please feel free to reach out to me. So there's a lot of noise outside if you can hear that. I'll be sending out emails, reminders about this certificate as well. Thank you.
Awesome. Thank you, Jonathan. I think that's it for I guess the final thing in terms of announcements. I think as I mentioned before, just November and December will be our kind of final member meetings online. So if you're interested or have any topics that you want, we plan ahead. So feel free to reach out about that. If there's any job announcements, please feel free to put in the chat, and we'll also put it into our minutes to send out to everybody. Looks like we may not be doing a member spotlight. Amelia, am I correct?
I believe we had somebody, but I'm looking through and I'm trying to see if they're here.
May not be here. That's okay.
Yeah, I will reach out and see. Maybe they had a hard time getting on with the new login. It says she's trying to join. Okay, there we go.
Yeah, she's trying to get on now.
Yep.
Yeah, it's a process. Let's see if she can get on. We can let her go, and if not, we can put her on for later.
What's Kelly's last name? I don't see her registered.
It's Massanelli.
Oh, okay.
Well, we'll go ahead and hopefully she'll be able to hop on, and we'll be able to let her do it later. But let's go ahead and pass the baton over to Patty. And throughout the presentation, Patty mentioned that if you have any questions, feel free to put in the chat. But she'll save some time at the end as well. So take it away, Patty.
And it's fine too for you to just start talking. I know that this is 21 people, and I think that often works well. So either way, let's see. I'm going to share my screen, and I just want to say in beginning that this PowerPoint, as well as the skills training packet, a Word document, are available. And I think Rachel can just put them in the chat right now. And then, you know, you can download them and use them. They're in PDF format just because I could get them to you that way. But if you want the slides in PowerPoint or the skill thing in Word, reach out and I can do that so that it's modifiable. My intention is to spread fact to benefit all the people you serve in primary care. So I'm with Mountainview Consulting Group, and I just want to start by saying that FACT was made in primary care. So it's so nice to have a psychotherapeutic approach that was really made in primary care. And just by way of history, Kirk Strassel and I met Steve Hayes in the 80s, the mid 80s, when dinosaurs roamed the earth. And Steve, by the way, is still kicking. I just saw him in Buenos Aires at the ACT WorldCon, and up to new things as always. But Steve was working in the context of the university, academia, and we were already moving into primary care at that point. So we were always shaped by our context. So FACT is different than ACT. And some of the key ways to keep in mind about that is our key differences are the fact that in primary care, we're always working as teams. And in primary care behavioral health model, we have this consultant kind of role. And we practice as according to the gather kind of model, which the E is about education. So FACT was shaped by the mission of trying to share behavioral science every day in every way with people that were a part of our team that had less training in mental health, substance abuse, and behavioral science in general. FACT was also designed for delivery in this generalist kind of way. So designed for delivery to children, youth, adults, and families individually, and any group starting with 2 and going up to 20 or 25, I guess, context. So that shapes it in many ways to be more pragmatic than ACT, I think, and to very clearly upfront from the moment we engage with someone, which is often same day, to focus on functioning and focus on family. So I'm really pleased to be with you all because you have that lens and of both primary care and families and people of all ages, because truly, if you can work with children and adolescents, you can work with their families, and true with adults too. If you work well with adults, you do have information about developmental psychology, or you seek it out, you seek training. And this is one of the great things about FACT. You can it can attract someone that's more trained with adults and help them take these basic skills and kind of wade into helping more and more children and adolescents. So as I said, it's gather friendly. And I wanted to talk just a little bit about the evidence for FACT in primary care, because we have a very large dissemination project now that's generating data at the national level. So stay tuned for updates. I'm going to share some information from the proof of concept study. And the site where you can read more is there on your slide. But this proof of concept study led the government of New Zealand to fund a national study, and the results of the national study convinced them, even before the research was concluded, to fund this approach throughout New Zealand. So they, rather than having a behavioral health consultants there, they have health improvement practitioners that would work better from a cultural lens than behavioral health consultants. So we have HIPs, and at this point, I think we have well over 400 HIPs that are serving between 75 and 80% of the citizens in New Zealand. All of, so I mean, just to translate what this means is that people can walk into a general practice clinic and most of the time see a HIP on the same day that's trained in focus, acceptance, and commitment therapy. And that increasingly HIPs are involved in wellness visits and introduced to families of infants and young children, and on their way to just becoming a part of good healthcare. Some of the more recent kind of population-based includes the finding that suicide rates in New Zealand have dropped over the past 3 years. So that's the first time in 17 years that there's been a drop in suicide rates. And it's in the past 3 years, and we've been disseminating since 2019. So that's kind of very encouraging to see that. It must be at least a part of it. So the data, though, that really moved the country was, I think, the finding of health equity, and that's equity in terms of access and equity in terms of outcomes. So there was no difference in the rate of referral and the rate of engagement between Maori, Pacific Islanders, Asian, and European populations. They used the Duke health profile, and then they used the SDQ, which is a measure with New Zealand data for children. And when we look at Maori clients, 74% reported well-being compared to 72% European, 71% overall. So not satisfaction was very high, and we did see a reduction in prescribing medications. So supportive of a skills before pills approach. So 57 to 70% of patients were seen on the same day as disclosing distress to the primary care provider. That was compared to the previous way of working 3 to 5% for conventional service and 75% within 5 days. They call what a HIP does talking therapy as a general term. I like it, yeah. And then they have built into their templates in their data collection for every single visit, different FACT measures, the FACT rating scales that you'll learn about later today. So those are reported on every visit a HIP has. And in this original study, the question at follow-up visit is in regards to the problem we or issue discussed in our previous visit. Would you say it's better, same, worse? And so we found that 62% better and 24% same. So that's everyone, seeing everyone, 86% stabilized or improving. So that looks pretty darn good. Also improvements in the broader determinants of well-being, such as housing and money matters, and that function to barriers to health, mental health and physical health and social health, as well as benefits for youth. And this, I just had to put this in for you because I was once one of you, and I worked in a rural healthcare center in, it was a migrant health center that with 17 full-time equivalent providers, so a large clinic in central Washington, Toppenish, Washington, a town on the Indian reservation, the Yakama Nation, that served a lot of people, a lot of Hispanic people, a lot of Spanish-speaking people. So this same question, same better worth in regards to people served 18 years or below 18 years of age, 67% improved, 33% staying the same. These were children that had very limited access to more intensive levels of care. And between 38 and 42% of my visits there at Yakima Valley Farm Workers Clinic were with people 18 and younger. So,
Did you go?
really lean into that educator role, and they feel confident about picking it up. And brief and powerful, and working for both medical and psychological problems. So that being said, I want to kind of blend into talking about how to use this fact medicine, but at the same time to talk about the evidence for using brief act interventions with children, adolescents, and families. So, yeah, we're trained to be generalists, and probably most people on this call see both adults and children. I did have the wonderful opportunity with Jeff Ryder to work with a large pediatric system in Milwaukee, Wisconsin for 3 years. And it was a lot of fun implementing PCBH and that context of pediatric care. So what is the goal of FACT? Well, it's to enhance psychological flexibility in parents and their children and teens. So knowing how to choose in the moment and to engage in behaviors that promote well-being is really what it's all about. And this goal of enhancing psychological flexibility really applies to the individual, the family units, and the community, indeed, the system of care in the clinic where you work. So all systems work better from individual to group with greater psychological flexibility. Different from the diagnose and treat model, symptoms are noted by FACT clinicians, but they are not the goal. Symptom reduction is not the goal. And it may or may not reduce. So that changes a lot of things. So acta non verba. I received the Don Block Award last year, and that if you haven't had a chance in family systems and health to read what Kirk Strassel and I wrote in accepting that award, take a look at it, because this acta non verba is an important kind of a way of working, I think, in the world as we see rates of mental health and substance use problems increasing and rates of availability or access to medical providers and behavioral health providers decreased. And what it really means is don't just talk about it, do something. So do something, measure it, and see how it works, and change it. And specifically with children, youth, and parents, help them get out of their heads and into their lives. I'm still going to get my tattoo that says that. I just haven't had a chance yet. So to break it down, there's the fact self. I did want to say there's a skills training packet for you to kind of peruse after the taste of fact today. I guess we would say the taste of fact. I do provide half day, full day, 3-day workshops on fact. I do webinars, consultation groups. Oh, and help me remember at the end, I will tell you about a fact intensive that's coming up in September. And if you really are like, I love fact, I want to learn everything I can, it's in Tacoma, Washington in September. And my colleague from Sweden that worked with Kirk and I in developing fact, Thomas Gustafsson, will be there, as well as Kirk and myself, and there'll be 5 days, lots and lots of workshops every day. And start your day with yoga, and in your day with yoga. That's one of my hobbies. So I'll be teaching you in very beginning level workshops at that. But breaking that, because most of you will not be there, I wanted you to have some of the materials, because we try to make these very transparent, so you don't feel like you have to have taken a college course or something, in fact, to start to integrate some of this approach to assessment, to conceptualization and formulation of interventions and delivery of interventions. You can pick and choose, take part of it, and then kind of grow your fact lens for working, so to speak. So I'm going to go over this fact self-assessment tool. It's really our effort to come up with some competencies that you can use kind of to self-assess. Where am I? What do I know? What do I want to learn next? The fact pillars of psychological flexibility help you identify what psychological flexibility looks like in a clinical conversation. Well, that's kind of hard to do, but if you start practicing and you have a learning buddy and you review this in consultation groups, it comes. The fact focusing questions are questions that we teach people to use after the contextual interview to say, what do I know? To begin to formulate, conceptualize, plan an intervention with this child, family, or adult that's in front of me. The fact Foursquare tool is similar in its assistance of new people to kind of sort it out. What are the person's strengths in terms of flexibility and less flexibility? What are their strengths and what are their needs? And what do they look like in the way of observable behaviors, and what do they look like in terms of behaviors that are appearing to occur within the individual and that they are reporting or describing. So the pillars of psychological flexibility. Engaged, and we sort them so that you can start to concept behaviors. You probably are using awareness also to empower that change or that discovery and then practice of a new skill. Same with engaged. So they're all interrelated. And most people have more abilities in one or two areas. So it's good to know what are their relative strengths in psychological flexibility and how can you leverage those. In this PCBH model, our goal is to be available to children, teens, and families throughout the lifespan. So when there are challenges, and there always are challenges, one developmental stage after another, or stress, these unplanned events that happen to us every day, when they happen, they can seek us out. We can quickly identify their strengths and identify their needs and help them grow their psychological flexibility throughout their life. Now, one of the key messages, you might take a picture of this so you can review it or put it someplace, write it down, write it on paper, put it on a sticky. And because this, if you can kind of start to really get your head around this, you're on the way to becoming, I think, a fact clinician. So every moment of psychological suffering offers an opportunity for personal growth. So that differs from the way many of us were trained, where we thought psychological suffering was a problem that needs to be eliminated. And if we deliver the right treatment, we'll be able to deliver it. So that's a big shift. These are the pillars of psychological flexibility: open, aware, engaged. So open, being open, the skills there are learning to be curious about your mind and body. Well, that is sometimes more challenging for our children and teens. And a lot of that has to do with what's the psychological flexibility of their parents. Indeed, the greatest predictor, single predictor of the psychological flexibility of a child or parent is the child or teen is the psychological flexibility of their parent. So we are always working with parents and trying to be curious about what they can or can't do at this point in time, and not make steps or plans or ask too much, because that takes them in the opposite direction of learning this skill of being curious about themselves and their response to their children, and modeling, teaching that curiosity about the mind and body to their child. Also, being open is learning about our emotions and coming to understand them and honoring them for what they are. They are wonderful signaling systems, things that we need to attend to and spend time with and honor, rather than control or suppress. Other skills in this open pillar are about learning to unhook. Part of the way our minds work is we just fuse. We can just fuse with our language, and we learn rules first from our parents, and the rules are protective of us sometimes. You know, we don't have to get run over by a car to learn the rule. Don't run into the street without looking. Because we follow rules. But if we get a rule that says, don't cry, then we can spend years, if not decades of our life, controlled and suffering more as we go through life, because we don't know how to unhook. We don't know how to name thoughts, see thoughts as thoughts, feelings as feelings, and sensations as sensations. So the aware pillar is about being in the moment. And I'm so glad you all, Rachel, are doing the digital ELO. I can't wait. I think I'm going to sign up for that, but I want to go to the gender too, Amanda. So I don't know what I'm going to do. But it's harder and harder, where we could actually just live in bed with screens around us and be completely entertained, and just go to the bathroom occasionally. And I guess they have workarounds for that as well these days for people that really get into screens. But awareness is about really feeling your feet on the ground, feeling your hand in your hand, and noticing the start of a breath and the end of a breath. And my nieces, one is more, she has very big emotions, even at 14 months. And her parents are working with her on her breathing. They're teaching her to breathe at 14 months. I just love it. And she looks at them and she's got these expressive eyebrows. She's mad and she's curious. What are they doing? And so this is things that we can teach from an early age. And this perspective taking and the self as context is so important, because we're storytellers. We're born storytellers, and we just make our experiences fit together. We make up all, we fill in the gaps quite automatically. And these stories, sometimes they work for us and sometimes they don't. And these are stories about other people as well as stories about ourselves. The other skills we teach, in fact, have to do with engaging really at a visceral level with what's important to us. And youth, our youth, it's all about figuring that out. So much of the time, our parents are telling us what our values are. But as we emerge into adolescence, we're getting opportunities to try things and learn from our direct experience. Did this connect with my heart, with what matters? And certainly we can talk with the little ones about values as well, because they understand what's important to their parents and they feel very connected to their parents. It's also about having skills for planning, doing, learning, and persisting. That is a huge skill group, a very, very big skill group that we don't learn all at once. We don't master it by age 18. It's skills that we learn, and I think skills that are best learned at the time. So I know we're gonna go into a little bit of data, because I want to share kind of how FACT and Brief Act is starting to move into different areas, and we're seeing more evidence accumulate. I think the curve in terms of the progression of ACT studies was like, for the first 20 years, the slope was like this. And then starting about 2017, it started going like this. And it's still going like that. And it's going in multiple countries. And many of the countries originally, and that's of randomized controlled trials, actually. Many of the countries are countries other than America, although now we see many, many studies in the United States. I think the rate of growth of studies for children, youth, and families using these, promoting psychological flexibility, is now starting. The slope has been slower, it's behind the adults, but it's increasing. So I'll just mention a few studies, but I think first I'd like to tell you about measures used to assess psychological inflexibility in children and adolescents. And so there's the Avoidance and Fusion Questionnaire for Youth, developed by Lori Greco way back in 2008. And there's a book that she wrote with Steve Hayes, I don't know, 3 or 4 years after that, that's all about using ACT with children. So take a look at that. But it is, the original measure was 17 items, identified 3 factors, and was reliable with children 11 and older and in adults. Psychological flexibility is an easier concept to measure in children like 11 and over because they have the cognitive development. But they did evaluate a shorter version, 8 items, and it appears to have good, adequate to good reliability with children in middle to ages 7 to 11. And that's nice, 8 items, 7 to 11. So that might be something, some of you are interested in program evaluation, might take a look at this. The citations are on there. And also important, no difference in factor structure between girls and boys. So anxiety is the first psychiatric condition to emerge in childhood. And what we see is a positive relationship between anxiety and psychological inflexibility. So I think we can help the growing number of children with anxiety by helping them with their psychological flexibility. This seems to be the case with older children and middle-aged children, strongest for panic disorder, and you can imagine why, lower for social and specific phobias. So we need to be teaching more skills there. I wanted to show you this. It's a 2018 study in Sydney, Australia, 193 children, 10-week group-based program of ACT or CBT. And both completer and intention to treat analyses revealed that ACT and CBT were superior to waitlist. That's good news. Similar. So there was some support, similar outcomes, but some support for ACT having greater effect sizes for quality of life outcomes. And the big question is, can we do this more briefly? Because these groups that last 10 weeks, that's a big ask for many of the people we want to reach. This is a review of prevention intervention programs for mental health difficulties in children and youth that reviewed 10 articles, looked at different things: anxiety, depression, obsessive compulsive disorder, anorexia nervosa, trichotillomania. And most studies found that mental health symptoms decreased and psychological flexibility increased following ACT interventions. This is really important, especially more and more we see like a PCBH spreading into schools, into medical facilities that are embedded in schools. So this is a trial that looked at a Finnish web and mobile delivered 5-week intervention program called Youth Compass. And they looked at 9th graders. This was just a general sample. And they found a small but significant decrease in overall stress and an increase in what they called academic buoyancy, which just means being able to stick with it in school and stay in school. And we know that's associated with all kinds of good things in adulthood. So this was also the case for students, regardless of their academic skills. So it didn't limit, but they could have lower academic skills, and it didn't limit the findings. But the intervention gains were highest among highly stressed participants. So it's called the Youth Compass program. So I think it may be very useful in general in the school context for promoting well-being and academic buoyancy in schools. This is a 2015. I want to make sure we have time for questions. So that's these are some more studies you can take a look at. That was another review study. This is one on parents, and that there is a measure for parents, the parental acceptance and action questionnaire. So we want to help our parents in any way we can. And this is just the relationship between their flexibility and their children's flexibility. I also wanted to say people are so creative. This is online and brief primary care groups that were helpful to parents to help their children and teens grow psychological flexibility. So they intervened with parents, but they measured psychological flexibility in children and teens. And it was online, brief, and in groups. So take a look at that. That's a 2022 study. But what do parents say? Describe their experiences as being non-reactive to their inner experiences and acting with greater awareness. Wow, wouldn't you feel good about yourself if you could help parents gain skills that? And children quality of life was improved and associated with parental well-being and their development of mindfulness skills. Also, dear to our hearts are our children's special healthcare needs, SHCN. So those that are at increased risk for a chronic physical, developmental, behavioral, emotional condition, and who also require health-related services of a type or amount beyond that required by children generally. So you may even have ways of identifying them through your electronic health records. So that you could target them, and now you have some evidence to inform what you might do. And I'm just going to have you look more at this if this is an area of interest. But it's a broad range of things that we can do. Group training for parents of children with autism, asthma, and actually, well, for children on the spectrum. My grandson, who's on the spectrum, he's 14. He's the one I took the road trip with recently. It has been wonderful for him, just wonderful. So, lived experience. And also in the way of preventive work. So this is work with families regarding obesity, overweight, and also those picky eaters. There's a 4-session protocol out there. That's in our wheelhouse. We can do that sort of thing. And this is just the table of contents from the document that I sent. For those of you who are like, I want to see some of these tools for doing ACT and try my hand. So there's the self-assessment tool, the contextual interview, the focusing questions that I mentioned, the bullseye, which is great with teens. I love it with lifestyle behaviors with teens. I've used it with them. I have a chapter on that. And then the life path, which is a powerful individual intervention, but it's with children, youth, but also good with parents and good in the context of a class. So this is the self-assessment, just the self-assessment tool gives you a chance to kind of say, where am I? Do I know this or not yet or whatever? And kind of target your learning 1 to 5. And you have 4 areas, but I think only 17 items. And so it's practice management, assess, case formulation, and interventions. So this goes through the items, so you don't even have to look into your skill training packet. Lots of things about workability, which is a really important part of the contextual interview, is helping people get perspective on what it is they're trying and how it's working in terms of what's important for them. This is a 4-square with some guides for how to use it after the contextual interview to start to train yourself to listen with fact ears. It's all about every visit from a fact perspective is about leaving that family, our child or teen, with a plan that involves their varying their behavior, going out and doing something they haven't done before to see what happens. We need to develop this and promote behavioral variability in every visit. So lots of interventions in here. I just wanted to tell you I did put in some books I think you might be interested in. Lisa Coyne is just a really, she does a lot of work with OCD. She's a great ACT teacher. Amy Morrell, she's in Memphis. I was down that way talking to the graduate students in the psychology program. They get the money to fund a training every year that they want, that they feel is not addressed in their graduate education. And I think, you know, we've got that gap where we have more and more faculty that are able to train and ACT, but there's still that lag of people being able to train with children. So these are, Chris McCurry is just one of my favorite people. He's in Seattle, Washington. So you might look at that. And then this is, there's another one, a workbook. And Louise Hayes and Joseph Chirachi, both in Australia, are just amazing. And they have this DNAV approach, which is, I think, really easy to learn and use. And they have an online training program that you might take a look at. So kind of just to leave you with a thought, a mantra for our children and young people. This might be something you print and put up on your wall. Everything that happens to you is an opportunity to choose thoughts and behaviors that help you use your energy to move towards your goals and values. Be tender with yourself. See the situation as it is, not more. That's the fact summer intensive. If any of you are interested in that, I can put it in the chat and I'll end that, and we have a few minutes. Yeah.
Wonderful. Thank you so much. Yes, let's open up to questions, comments.
Excuse me, Patty. I'd like to put a plug in for the coping strategies use scale and ask you if you've applied that to pediatrics.
Yes, we have, but we haven't evaluated it. You know, in pediatrics, you know, it's so interesting, David, because the age of what is adolescence, it varies depending on who you look at. You're that's right. Somebody told me a funny story. It says they were trying to look at older people and understand this guy was 83. And so they went out to interview him. It's your birthday. You're 83. How do you feel? And he says, well, I don't feel 83. I feel 23, but I feel like there's something wrong with me, my body. I thought it was so funny. But this CSUS, you know, is very applicable starting, you know, 14, 15, 16, 17, 18. So, and it's very, it's easy. We do have data that say that doctors understand those items, people understand those items. And David, if you have it available, can you just put it in the chat for people? It's an alternative to the PHQ because what it is it's I wrote an article in Family, it was published in Family Systems and Health in 20, maybe, yeah. But 2022 maybe. And the American Psychological Association picked it up and did a scientific spotlight. So you can find the data and a short thing if you search APA Spotlight, coping strategy use scale. And so it measures what you want instead of what you don't want. And so, it can be very useful in pediatrics, which the upper age range would be 26. So depends on who you're asking. Other questions?
I had a question about the kind of applying skills to some of the younger kids. So you had mentioned earlier that maybe it was your granddaughter was learning some skills at 14 months, which is like, that's so impressive. And my mind is blown because I have a 15-month-old. But I guess I was wondering in terms of like, at what age do you kind of start using some ACT skills with kiddos in your practice? And I'd like to see also too that you have practice for parents, which is really important. But thinking in terms of some of like the metaphors and the experiential exercises in ACT, like how do you apply it, kind of the younger age ranges?
I think I would say, from birth, and even before birth, I think working with their parents because they are launching into the most difficult job they've ever done in their life without even a training manual. How do I learn this? And, I watch my daughters, I have 3 of them, scramble looking on the internet, trying to figure things out. So, just approaching parenting or pregnancy with greater psychological flexibility would be a real A-game move. So how we teach it though, Rachel, I think what you're talking about is how do we teach a 14-month-old or a 15-month-old? So we're always teaching their parents because they're the ones that are going to assure the practices. But if we can manage to get some kind of dialogue going, interaction going with that baby or that 3-year-old that's throwing a fit or that's unusually active in our office, and we can model some behaviors, then the parents start to pick it up. But we need to be able to kind of get some credit one way or the other. And I think we do this by acknowledging how difficult the situation is and how hard it is to change even one little tiny thing about the way we react, because we're constantly having to act and interact and to address things. These little ones come up with something new every day. So I think one of the core skills with the little bitty ones is just, assuring them that this will pass, it'll be okay. So not getting into that struggle with them, which, I think it starts early, that struggle that you're not okay. And you need to stop that because that makes me feel I'm not okay. And I can't have that. So that awareness, acceptance, and that confidence. Yeah, that at some point they are going to learn something new. They are going to move forward, and that you can model something that seems to work for you. And it might be just, whistling or singing or something. But you are modeling psychological flexibility when you don't try to suppress or control or avoid your child and their child's experience. Starts young. Yep.
Yeah. Thank you.
read some of those books for parents would be good.
Yes, yes.
Patty, I posted the spotlight article. If there's anything else, I don't have it.
Okay, no, that's great. It references if you want to look at the science behind the brief. Yeah, this is associated with good things. Teach these things. And when we did this randomized controlled trial, again, we were developing fact. So in primary care. So thank you all so much for your time today. Rachel, thanks for hosting. Thanks for your questions. And I'll see y'all in San Antonio, I hope. Yeah.
Wonderful.
At 7:30 Saturday morning.
Might be 7 a.m.
Oh.
I know.
All
Yeah,
right.
but thanks so much. We really appreciate it. Very informative. Thanks for coming, everyone.
Thanks.
Have a great day. Bye.